Bismillahirrahmanirrahim. Today in continuation with the disorders of the gastrointestinal tract, uh, today we will discuss the esophagus, and in the esophagus we will discuss the obstructive disorders. The normal adult human esophagus is 25 centimeter long, and the length varies in children and according to the age and physique of the person. It is a muscular tube extending from the pharynx to the stomach. The pharynx, which is divided into the nasopharynx, oropharynx, and laryngopharynx. So the oropharynx of the oral cavity is continuous with the esophagus, which runs behind the trachea and the heart and in front of the vertebral column, and pass through the diaphragm to join the stomach at its cardiac end. For our convenience, we divide the esophagus into cervical, thoracic, and abdominal parts. There are three narrow points or anatomical constructions in the esophagus. The first construction is really the upper esophageal sphincter, which lies between the pharynx and the cervical esophagus, and mostly the upper esophageal sphincter, it is formed by the cricopharyngeus muscle. The cricopharyngeus muscle being a skeletal muscle, so the upper esophageal sphincter is composed of skeletal muscle fibers. And the second constriction, which is located at the bifurcation of the aorta into its main bronchi, left and right bronchus, and here in this region also lies the aortic notch. The third constriction that we say is the lower esophageal sphincter, and it is situated where the esophagus passes through the diaphragm to enter the stomach. The upper esophageal sphincter and the lower esophageal sphincter, these are the two high pressure zones, and they prevent the backflow of food. The upper esophageal sphincter and the lower esophageal sphincter, they are involuntary and are not under the control of the person. When we go to the nerve supply of the esophagus is supplied by the vagus nerve, which is the parasympathetic division of the autonomic nervous system, and the cervical and thoracic sympathetic trunks, which are the sympathetic divisions of the autonomic nervous system. Now, the cross section of the esophagus and most of the gastrointestinal tract is composed of the inner mucosal layer surrounded by the submucosa, and outside the submucosa is the muscular layer, and outside the muscular layer there is the adventitia. The adventitia and serosa are the same words that we use, but what happens that when the retroperitoneal region of the digestive tract, by that we mean that those parts of the digestive tract which are firmly attached to the surrounding structure by connective tissue fibers, and in these parts, this outer covering, we call it as the adventitia. The intraperitoneal region of the gastrointestinal tract, those parts that are suspended in the peritoneum, most of the gastrointestinal tract, it is covered by the mesothelial cells of the serosal layer. Going into a little detail in the cross section of the histology of the esophagus, we see that the lowermost layer known as the mucosa, and in the esophagus it is composed of stratified squamous epithelium. Outside the mucosal layer there is submucosa, which is composed of loose connective tissue, and outside the submucosa there is a muscular layer which consists of an inner circular and outer longitudinal layers of the muscle fibers. Outside the muscular layer is the adventitia, and this adventitia in the most of the stomach and lower gastrointestinal parts, it is known as the serosa, which is the form the visceral and peritoneal layers. Important here is the presence of the nerves, particularly in the submucosa of the esophagus lies the Meissner plexus. These nerves of the Meissner plexus are mainly responsible for the secretory activity of the organ. In between the muscular layer there is another nerve plexus known as the myenteric plexus, and it is associated with the contractions and motor activity, and particularly the peristaltic movements that happen in the gastrointestinal tract and as well as the esophagus. Here one important thing that I want to clear, that the food that we take into the mouth passes through the upper and lower esophageal sphincters, and this is an active peristaltic movement. It is not simply due to the gravity that we may say that the food falls from the esophagus into the stomach. This is not the case, and actual peristaltic movements, they push the food through the esophagus into the stomach, and gravity may play a small part. Now coming to the disorders of the esophagus, we for our convenience divide the esophageal disorders into obstructive and vascular diseases. Now the obstruction may be caused by mechanical obstruction, or it may be functional obstruction, problem in the nerves and muscles, and failure of peristalsis. Ectopia is another condition in which an external tissue like gastric mucosa or gastric tissue, it is lying in the esophagus that normally that should not. The vascular diseases, which are the problems associated with the blood supply, is very important, and esophageal varices, they are very important, and they result from the anastomosis of the aortic and portal circulations, and we will discuss them in detail. Now inflammation of the esophagus, which is known as esophagitis, it may be caused by many factors. For example, lacerations that occur during excessive and forceful vomiting. There are many chemicals and infections by microorganisms that can cause irritation and inflammation in the esophagus and can give rise to esophagitis. The reflux esophagitis is a condition in which the contents of the stomach, they are regurgitated into the lower part of the esophagus. So what happens, that we know that the esophagus actually it is lined by the stratified squamous epithelium, while the lining mucosa of the stomach is these stratified columnar epithelial cells. So when the stomach contents are regurgitated into the esophagus, they may irritate the esophagus and cause reflux esophagitis. The eosinophilic esophagitis is a condition that we discuss further, and it is characterized by the infiltration of the eosinophil granulocytes. The Barrett esophagus is a very important condition in which what happens, that the stratified squamous epithelium in the lower esophagus, it is replaced by columnar epithelium, and so in Barrett esophagus, this type of metaplasia in which stratified squamous epithelium is replaced by columnar epithelium can give rise to so many complications like ulceration, and the most important and serious condition is the adenocarcinoma. Now, in the next to esophagitis, we will discuss the various tumors that occur in the esophagus, and the most important are the adenocarcinoma, cancer of the glandular epithelium, and squamous cell carcinoma, which is cancer of the stratified squamous epithelium. Now, mechanical esophageal obstruction, most commonly it is due to birth defects. Atresia is a condition in which a segment of the esophagus in the newborn is replaced by a thin non-canalized cord. So, by atresia means absence of the esophagus, and it is being replaced by a thin non-canalized cord. Fistula is the condition in which the esophagus is connected to a bronchus or trachea, and mostly the atresia and fistula are commonly found together. And for these disorders, prompt treatment and prompt surgery should be done, otherwise they will give rise to serious complications. In some cases, there are two esophagi, and this condition is known as the duplication. Mechanical obstruction of the esophagus may be caused by esophageal stenosis. And what happens in esophageal stenosis, that there is fibrous thickening of the submucosa. Normally, the submucosa is made of loose areolar connective tissue. But in esophageal stenosis, it is converted into a strong and thickened fibrous tissue. And additionally, the atrophy of the circular and longitudinal muscles occur due to mainly by inflammation and scarring after the chronic gastroesophageal reflux disorder, in which the stomach contents are regurgitated into the esophagus. This esophageal stenosis may also be caused by irradiation and sometimes caustic injury in the form of, for example, corrosive oils or other chemicals. They can cause esophageal injury, which is later on during the process of healing, the submucosa is converted into a thickened fibrous tissue, while the muscular layers, they undergo atrophy. Now, in this situation, there is dysphagia, which is difficulty in swallowing, and mostly the dysphagia occurs with solid food initially, and later on this may also be due to liquids. Now, sometimes there are tumors outside the esophagus that compress the esophagus and make it narrow and difficult for the food and liquids to pass through it. Now, in addition to the tumors, some external compressions, for example, by left atrial enlargement of the heart and an aneurysm, or a pouch which is found in the aorta, it may be compressing the esophagus, and tumors that occur in the thyroid gland, which is very close to the esophagus, and it may, if large tumors occur or if there is thyroid enlargement, it may be compressing the esophagus. Now we come to the functional obstruction of the esophagus. Up to now we discussed the mechanical obstructions that can cause difficulty in swallowing foods and liquids. Now, in the mechanical obstruction, the most important condition is known as the achalasia. A means no, and chalasia means relaxation. So it is clear by its name that achalasia happens when the lower esophageal sphincter doesn't relax. Normally, when we take food, we take food into the mouth, the food is chewed, mixed with the saliva, and it forms a bolus which is propelled by the tongue and the soft palate into the oropharynx. Now, the pharyngeal muscles push the food into the upper esophageal sphincter, which gets opened by the swallowing reflex. And the upper esophageal sphincter, as I told, it is formed by the mostly by the circular cricopharyngeus muscle, and it is situated at the top of the esophagus. Now, due to swallowing reflex, the upper esophageal sphincter relaxes to allow food into the esophagus, and at the same time, the lower esophageal sphincter opens and it allows food to pass into the stomach. As the food enters the stomach, these sphincters are closed, and here it is important to say that these sphincters are not under the voluntary control. Now, sometimes we think that food may pass from the mouth through the esophagus into the stomach due to gravity, but the gravity has got a very slight role. The food is actually propelled through the esophagus by active peristaltic movements, and these active and coordinated peristaltic movements are very necessary and required for the normal passage of food and liquids from the esophagus into the stomach. Now, the upper esophageal sphincter is formed by skeletal muscle, while the lower esophageal sphincter is formed by the smooth muscle. And the nerve supply of the esophagus, it is mainly supplied by both the parasympathetic, which is the vagus nerve, and the sympathetic nerve from the sympathetic nervous system, which are parts of the autonomic nervous system. Now, what is achalasia? It is a functional esophageal motility disorder, and in which what happens that there is accumulation of food and liquids above the lower esophageal sphincter, which remains constricted and doesn't relax, and the accumulation of food will lead to the distension of the esophagus, part of the esophagus which is above the lower esophageal sphincter, and it will become enlarged and dilated and is known as the mega esophagus. Now, going to the causes of achalasia, three conditions they provide and facilitate the condition. When there is incomplete lower esophageal sphincter relaxation, or if there is increased lower esophageal sphincter tone, and sometimes loss of peristaltic movements in the esophagus. So these conditions in combinations will give rise to the achalasia, and the lower esophageal sphincter, it remains constricted and it doesn't relax, so the food is not passed into the stomach and it is accumulated above the structure or the constriction which is formed in the lower esophageal sphincter. Now, achalasia may be a primary condition, primary achalasia, which is characterized by unknown degenerative changes that occur in the parasympathetic nerve supply, and which lead to the failure of the distal esophageal inhibitory neurons that normally inhibit the constriction of the lower esophageal sphincter. So when the inhibitory neurons, they are made unable, so they do not inhibit the constriction, and the esophagus, particularly the lower esophageal sphincter, it remains in the constricted position. This is the primary achalasia. Now, achalasia may also occur secondary to another diseases, in which particularly the parasitic infection known as the Chagas disease, which is caused by the Trypanosoma cruzi, a parasite which infects and cause the same type of mesenteric plexus destruction in various parts of the gastrointestinal tract, and It may also cause destruction of the mesenteric plexus in the lower esophageal sphincter, but in this case, the achalasia is secondary to a primary disease, particularly the parasitic infection known as the Chagas disease, which is caused by the parasite Trypanosoma and cruzi. Now, whatsoever the primary and secondary achalasia, there are other conditions in which there is no true achalasia, but achalasia like disease is produced. For example, in diabetes mellitus, which is particularly characterized by the neuropathy, nephropathy, and retinopathy. So, diabetic neuropathy may also cause damage to the nerves of the lower esophageal sphincter and may cause a condition which simulates the achalasia. Some infiltrative disorders, for example, amyloidosis, sarcoidosis, and malignancy, cancer, they may also destroy the same uh, nerve supply to the lower esophageal sphincter and may cause a condition which simulates the achalasia. And poliomyelitis also affects the nervous system and may cause uh, destruction of the nerves of the lower esophageal sphincter and may result in a condition that simulates the achalasia. Sometimes during surgery, particularly the cranial surgery, the dorsal motor nuclei, they are destroyed during the surgical procedure, and later on it may give rise to the achalasia or functional esophageal obstruction. Now, what are the symptoms of achalasia? Actually, what happens that the abnormality in the esophageal motility occurs due to an imbalance between the nitric oxide and acetylcholine neurons in the esophagus. And both of these types of neurons, the nitric acid and acetylcholine, their production is decreased, their activity is decreased. And what happens that the nitric oxide and acetylcholine, which prevents constriction of the lower esophageal sphincter, when they are decreased, automatically the lower esophageal sphincter will remain in a constricted position. The symptoms of the achalasia include the dysphagia for liquids and solids. Mostly the dysphagia for solids occur before the liquids, and there is regurgitation of the esophageal contents because they are not allowed to pass through the lower esophageal sphincter into the stomach. Sometimes there may be chest pain, which is actually not the due to heart, and automatically chronic anorexia and inability of the food to pass into the stomach will cause in weight loss. And moreover, the food that is resting in the esophagus above the obstruction, above the lower esophageal sphincter, it may undergo fermentation and it will produce pain that simulates the heartburn, which is regurgitation of acidic stomach contents into the esophagus. But here there is no regurgitation of acidic contents from the stomach into the esophagus, but actually the food that remains in the esophagus and is not allowed to pass into the stomach, it undergo fermentation by bacteria and it will give rise to a condition like heartburn, we say. Now here in this picture we can see normally the lower esophageal sphincter, which when food is swallowed through the esophagus through ectoperistaltic movements, it opens and allow food to enter into the stomach. But what happens in the second picture, which is from achalasia, in which the lower esophageal sphincter doesn't relax and the food remains above the constriction and the esophagus gets dilated, and during the diagnostic procedures we may do barium swallow, and the esophagus in this condition may give the appearance of a bird's peak appearance of the lower esophageal sphincter with dilated upper portion, which can be seen on barium swallow, and the dilated upper portion will present the dilated and megacolon. For the diagnosis of the esophagus, the most important is the gastroscopy, to use a gastroscope or endoscope and to confirm the obstruction. Barium swallow, which will give the appearance of the bird peak appearance found by the tapering of the inferior esophagus, which happens in achalasia, but it should be confirmed that even sometimes normally during the barium swallow such like appearance can be seen. And another condition in which the pressure in the esophagus is measured and which is known as the esophageal manometry. And during achalasia, we know that the two sphincters, the upper esophageal sphincter and lower esophageal sphincters, they are the zones of high pressure. They are known as high pressure zones. And during achalasia, since the pressure in the lower esophageal sphincter is much more, it can be measured by the esophageal manometry. Now, the treatment of achalasia is uh, manipulating and dilating the esophageal sphincter. It may be done by using an endoscopic myotomy, which means cutting the lower esophageal sphincter in such a way that we make a passage through it and through which food can pass from the esophagus into the stomach. So these procedures can be achieved by either doing endoscopic myotomy, which is a less invasive procedure. However, in some conditions, surgical procedure is needed to relax the lower esophageal sphincter and to treat the problem. Now, another condition which may occur in the esophagus is known as the ectopia. Ectopia. By that we mean that ectopic tissue lies in the esophagus. We know that the esophagus is lined by the stratified squamous epithelium, while the stomach or the gastric mucosa, it is formed by the columnar epithelial cells, which are secretory cells. And what happens that sometime congenitally at birth, the esophagus gets lined by in some of its part by the gastric mucosa. Gastric mucosa that normally occurs in the stomach and it should not be in the esophagus, but if there is a patch which particularly occurs in the upper third part of the esophagus and is known as the inlet patch. And here what happens that we find ectopic gastric mucosa in the upper portion of the esophagus. In most of the situations, the ectopia is asymptomatic and it doesn't give rise to any symptoms or signs. But sometimes if substantial amount of gastric mucosa, if it is lying in the esophagus, what happens that like the gastric mucosa in the stomach which release hydrochloric acid. So this gastric mucosa in the esophagus will also start secreting hydrochloric acid and it will give rise to the conditions like difficulty in swallowing, dysphagia and irritation of the esophagus, which will cause esophagitis, and sometimes it may be responsible for the Barrett's esophagus, which is mainly the condition that occurs in the lower portion of the esophagus in which there is metaplasia and the stratified squamous epithelial cells the stratified squamous epithelium undergo metaplasia and is replaced by the columnar epithelial cells that normally lie in the stomach. And sometimes, very rarely, the ectopia or the inlet patch which lies in the upper third of the esophagus, it may give rise to the cancer known as the adenocarcinoma, which is a cancer of the columnar epithelial cells. However, this condition is rare. In this picture, we can see through an endoscope the comparatively red and prominent uh, spot, which is an inlet page or ectopic tissue. And here we can see the presence of gastric mucosa in the esophagus, and however it can be confirmed by the histological examination. Thank you very much.